Lovely, thank you, Sandra. So yeah, I'm Nikki McFarlane. I'm the lead nurse for enhanced support. Just everyone pop themselves on mute. So I'm the lead nurse for enhanced supportive care at Lewisham and Greenwich, and I'm also a primary care cancer facilitator in Southwark. And I'm just going to do a brief introduction today to enhanced supportive care and supportive care before handing you over to Pauline and Lucy, who are the real experts, to go through their service. So if we just have the next slide, please. And the next slide. So I thought I'd just start by looking at what is supportive care, and by no means a new concept in cancer or generally, but originally in cancer was first described by a Canadian nurse called Margaret Fitch back in 1994, and she developed the supportive care framework for cancer. And she designed it originally as a tool for cancer professionals to help see what cancer patients might need, and help to plan service delivery and see at which points they would need more help. And she very much identified that supportive care is required at different points in the cancer pathway, and not all patients will require supportive care at all time points, but there are different points along the journey where it is more important for patients to receive supportive care. And again, that just if we look at the Multinational Association for Cancer Care definition of supportive care, that's sort of echoed in that as well. In supportive care is the prevention and management of the adverse effects of cancer and its treatment, which includes management of physical and psychological symptoms across the continuum of the cancer journey, all the way through from diagnosis to treatment and post-treatment care. Let's go to the next slide, please. So just to look at enhanced supportive care then, and where does that come in? Enhanced supportive care is just an intervention that promotes earlier implementation of supportive and what we think of as palliative care, and we generally tend to think of it as end-of-life care, but putting that in at an earlier time point. So not waiting till the patients are at that end-of-life stage or in a crisis, but putting that in earlier, and looking at it with a more positive, individualized approach for patients who are living with cancer. So very much along the lines of the personalized care agenda, looking at what's important for patients and at what time point that's important for them. Originally, it was a sequin back in 2016, based on some work done at Christie up in Manchester. And the model of enhanced supportive care there was focusing on the integration of supportive care at the point of diagnosis of incurable disease, so that it could be available to patients alongside cancer therapy. And so there are different models of enhanced supportive care, but generally they are for patients with incurable disease that's treatable. So they're having some sort of treatment, but they have got incurable disease. There are 6 principles that go alongside the framework. The first being the much earlier involvement of supportive care services. Importantly, number 2 is teams that support cancer patients should work more closely together. So that's not just about colleagues within the hospital, our dietitians, our physios, our OTs, but that's also looking at our primary care and community teams as well, and how we can work together to support the patient. And then adopting a more positive approach to supportive care, cutting edge evidence-based practice, technology to improve communication, and best practice in care of patients undergoing chemotherapy. Next slide, please. So just looking at that group that we described, this treatable but not curable group, advances in treatment over the years, have shown that people now live for several years with treatable but not curable cancer. Macmillan, among others, has highlighted the importance of identifying these patients because they have different needs to those patients who have cancer that has a cure or who are at the terminal phase of diagnosis. Macmillan estimate that the number of patients it ranges from about 136,000 at a conservative end all the way up to as high as 250,000. And just to put that into context, that's about the same number of patients that have got multiple sclerosis and Crohn's disease together. So it's a big chunk of patients. Unfortunately, due to the COVID-19 pandemic, it is estimated that approximately 10 to 12% of patients who would have been diagnosed in 2020 have not yet presented. So when they unfortunately do, they are going to have more advanced disease. It is going to need more aggressive therapy, and they will have a reduced likelihood of cure. So this group of patients is only set to grow. Next slide, please. Next slide, please.
Sorry, Nikki, it's showing on my screen,
okay,
is there
it's up. It's up now.
Sorry, there's a slight delay. I'll try and be faster.
No problem. So how does that all fit in with community and primary care? Well, it's everybody's business to understand what's going on, across boundaries, across from acute care into primary care. But these patients are going to be patients that you're going to see more of, and therefore it is important that we have an understanding of what the services that are available to them and the kind of needs that they have. These are patients that are going to have, not always, but they are more of them are going to have drains in situ, so pleural exchange, pleural effusion societies. They're likely to have CVADs, central venous access devices for their chemotherapy, so PICC lines and portacaths that you might see in the community. One of the aims of enhanced supportive care is that we bring conversations like advanced care planning forward. So we're not waiting until patients are more towards the end of life, but we're doing that at the point of diagnosis with incurable disease. So we're having those conversations early, and in London, using urgent care plan to document that. So all our colleagues across the sectors in London can see those care plans. Cancer care reviews. So in primary care, cancer care review is done at 3 months and 12 months post-diagnosis. So those patients will still be having those cancer care reviews in primary care. And it's important that you understand, as was described earlier, that they do have a different set of needs. They are having chemotherapy or some sort of therapy, so they've got those needs as well, but they've also got their incurable cancer needs as well. Social prescribing, so a great resource that we have in primary care, and when we look at the top 10 reasons why patients what the reasons that they have and the problems that they come up with, I think 7 out of 10 of the top 10 are social reasons. They're financial reasons, their loneliness, their social isolation. They're things that social prescribing really can identify and help with, and that's a great resource that we've got in primary care, which we can refer them to. There is a CoP measure, PC001, which is that there should be a palliative care register. Now, traditionally, this would be the palliative care patients you think of as end-of-life patients, but more and more we should be putting those enhanced supportive care patients on there as well. So it's important to understand why those patients might be on the register and that they're not needing end-of-life care, but they have got incurable cancer, and we're recognising that earlier. We're putting them on our lists and therefore having discussions about them, so that when it does come to the point when they need to transition to end-of-life care, that's a more seamless transition. And then just generally,
Nikki, just giving you a 60-second warning.
Generally, just better communication between acute care, GP practices and community means a better service for our patients. If we're all working together, these patients are in their last years of life. That means a better service for the patients generally. Last slide, please. And then just in the last 30 seconds, just a little look at service provision. As I said, it is a new service, well, newish service. And so this is 2019, but you can see the services throughout the country there. And then in London, particularly, we've got Barking, Havering and Redbridge, Royal Marsden, Chelsea and Westminster, UCLH, and a new service being set up at Lewisham and Greenwich. And I'm going to finish there and hand you over to Lucy and Pauline from Barking, and they're going to tell you about their model of enhanced supportive care. Thank you.
Hi, good afternoon, everyone. Thank you so much for joining us. My name's Pauline Staley, and I'm the joint team leader with my colleague here, Lucy Summerfield.
Hello.
Of the Enhanced Supportive Care team at Barking, Havering and Redbridge University Hospitals. Next slide, please. So we thought we'd begin by just giving you a little bit of background about the trust that we work within. So we're a large acute trust that serves 3 London boroughs with a population of around 800,000. 2 of the 3 London boroughs represent the highest socioeconomic deprivation within London. We operate from 2 sites. One is Queen's Hospital in Romford in Essex, and we have King George's site in Ilford. We have approximately 900 inpatient beds across both sites. But I think the most significant thing to take from this is that we have a very well-established specialist palliative care team already that covers both sites within the trust, and they provide a 7-day service for all inpatients. And here at Queen's, we're the regional centre for radiotherapy and on-site chemotherapy day unit. Next slide, please.
So just kind of carrying on from what Nikki said about enhanced supportive care, it was this national initiative that was set up to promote this better access and early integration of supportive care, mainly within oncology. And obviously our specialist palliative care team cover all end-of-life patients, all patients with specialist palliative care needs, even if they've got non-malignant disease. So this was purely for oncology and oncology based. And it's about promoting early identification of patients that have got an incurable cancer. And it's about supporting patients in a proactive manner to help them with decision making and planning of anti-cancer treatments, and about people getting early access to help manage some of the adverse side effects of cancer and the cancer treatments that they might have. And it's been proven that timely supportive care in a positive way really does improve patient experience and outcomes, as well as reducing the need for these hospital crisis admissions that are a big problem for everybody, not just the patients, but financially here for the trust as well. Next slide, please.
But I think we recognise that's all very wordy. The real essence of enhanced supportive care is about introducing palliative care expertise at the very beginning of a patient's diagnosis of incurable cancer. And that's where the difference is. And patients are much more receptive to it because it kind of blocks the automatic association with sort of terminal illness and loss of hope that often patients find when they're initially diagnosed. They find that word palliative as really scary, even though they may well have been told that their cancer is treatable but not curable. It is often quite difficult to introduce palliative care right at the very beginning. And it's not about blindsiding or hoodwinking anybody. We're always transparent that we are palliative care nurses and that we are Macmillan nurses, but they just seem more receptive to that word supportive care. And it is currently viewed by NHS England as best practice in cancer care, and received a Quality in Care Patient Care Pathway Award back in 2016.
So we thought we'd just tell you a little bit about in the beginning about when we set up our service, as we were part of the initial sequin back in 2016, and we were funded for 2 years to implement this service. And we felt it was very important we set up separately to our existing palliative care team. Nationally, all enhanced supportive care teams are very different. Some rebranded their existing palliative care teams, but because of the money attached to the sequin, we felt it would just get absorbed and would just be lost within the main palliative care team. So it was important to keep it very separate so we could focus down in oncology. And we had to obviously appoint staff, which was quite challenging because it's a very new concept. So how do you find enhanced supportive care nurses when it is so new? But we found kind of a mixture of oncology and palliative care experience was a really good background and good place to start. So me and Pauline were seconded from the palliative care team here to set the service up. We had to identify 3 tumour groups initially to focus on, and those tumour groups, we had to pick ones that had the worst outcomes when they were diagnosed with incurable disease, and that had quite a heavy symptom burden at diagnosis. And also for the actual trust, we looked at the National Cancer Experience Survey to see who was feeling about that things were really tough for them or they weren't getting the best experience. So we initially went with lung cancer, upper GI cancers and cancer of unknown primary. And we completed an audit just to see how many of those patients at diagnosis of incurable disease were actually offered supportive care or palliative care at that point. And coming from the palliative care team here at the Trust, we thought, well, it's going to be quite high numbers. But actually, it turned out only about 30% of patients were offered any form of specialist palliative care at diagnosis. So that meant there was this whole 70% left with absolutely nothing until they were perhaps in crisis or actually came into the hospital.
Next slide, please. Oh, sorry. Oh, it's there. Sorry. Okay, so like Lucy said, we wasn't sure what this was going to look like. The national guidance was really fluid, and although we were very well supported by NHS England and by the clinical lead at that time from the Christie, there wasn't really any guidance on how you were going to run the service. So we very much had to look at how it was going to work for our demographics and our diverse ethnic community here at BHRUT. So it was very much a bit of trial and error to begin with. And initially, we decided we don't need a referral form. We have access to all the systems with all of the patient information and scans and things. We don't need somebody's interpretation. So we were like, how do we identify these patients? And we originally sort of sat in MDTs, but we found that was really time consuming and actually not a particularly good use of that time. So we now use our data collector because we're very fortunate to have one, and she goes through the weekly MDTs every week for the tumour groups that we have. She looks through all the documentation and MDT outcomes, and she has the skills and experience to identify those patients that meet the criteria to be referred to our team. And that criteria is non-curative at diagnosis. It is as simple as that. So we're very fortunate to have our admin. We now cover 5 tumour groups. So we continue with lung, upper GI and cancer of unknown primary, but we've taken on 2 very large cohorts of urology and secondary breast cancers. And we are incredibly aware that there is no equity in service here. There are 6 cancer tumour groups that we don't cover. We don't think that's reasonable and fair. However, the Trust is in financial special measures, and it doesn't matter how many times we put forward a business case for 2 new CNSs, we just can't get funding at present. But we will keep trying, and we've looked at many alternative ways of funding staff within our service. And we've been very fortunate to have some funding from North East London Cancer Alliance as well. I don't think I finished that slide, did I? No. Okay, so just to recap what our service looks like, we have a 5-day-a-week nurse-led telephone and virtual clinics. We have a 5-day-a-week nurse-led face-to-face clinics as well. And obviously, all of those appointments and things are documented, and we do obviously get funding from you guys out there in primary care, so we can show some evidence that we are actually accruing some money for the Trust. Our face-to-face clinics are very ad hoc. We are very aware of the burden of treatment with our patients, so we tend to try and either sort of attach onto an existing appointment, or we will try and see them when they're in the day unit or when they're having their radiotherapy, when they're coming up for a scan, when they're having a blood test. We try to do whatever we can to make their life easier. And then what we try to do within that is regular updates to our community teams, but we'll touch on that a little bit later.
Yeah, and I think if I can just give you a quick example as well of how the telephone clinics and the virtual clinics work quite well. We try to be proactive in ringing people to kind of avoid any crisis admissions, so to be proactive rather than reactive. And I can give you an example of a young lady that we had who was in the last months of her life, and she'd actually received a call that morning to say her recent restaging scan had said that she had a large PE and she needed to come into A&E to be seen and get some anticoagulation. But from speaking to her on the phone, we were able to avoid her coming up to A&E, because through conversations with her consultant and then with the community team, so with the district nurses in her area, they were able to offer to go out to her in the community and actually administer the first dose of Clexane there, rather than her coming up to the A&E department for that. And it took a little bit of work to get the prescription, to get kind of the authorisation for that. But through working jointly with the district nursing team, it actually worked really well and avoided this lady who was in a lot of distress anyway, actually coming up and sitting what would have been hours in the A&E department, just because the community team were really proactive in wanting to help and support this lady. And because we'd been in quite close contact with them about her already, they were able to support us and make sure that happened. So that was really quite a nice example of how we do jointly work with our community teams.
And I think what we do an awful lot of is symptom management, as our background is specialist palliative care. So we do a lot of symptom management and drug changes. And Lucy's a non-medical prescriber, but the patients don't always want to come up to the hospital to get their prescriptions. So we do an awful lot of communicating with the GPs and requesting drug changes from them. And if it comes from us, they're very happy to respect our area of expertise, and they generally do what we ask them to do. So that's all really good for the patient as well.
Next slide, please. So kind of just to tell you a little bit about where we are now as a team, we're actually a team of me and Pauline are a 1.2 whole-time equivalent. We've got a full-time enhanced supportive care clinical nurse specialist and a full-time clinical nurse specialist who focuses purely on the metastatic breast patients, because they're quite a needy group who need one nurse to focus on them. We've also got a Macmillan support worker who's band 4, who's absolutely fantastic for both the breast patients and for all the other enhanced supportive care cohort of patients. And we were actually fortunate to get funding from the North East London Cancer Alliance for a part-time advanced care planning clinical nurse specialist, which fits in perfectly with what enhanced supportive care is all about, because she's able to actually be in clinic and have those advanced care planning discussions early. She runs her own clinic where she can document patients' preferred place of care, death, and really push for DNAR forms to be completed. And she will then upload all that information onto the urgent care plan register and disseminate information to GPs and community teams. And it's actually been working really quite well, and the evidence has shown that quite a tremendous uptake and people that are really interested and keen to have those conversations. So we feel that her role has been really valuable to enhance supportive care.
Yeah, and I think what we recognised is that there was some very rich conversations happening down in oncology clinic, and they weren't always being disseminated with our primary care and community colleagues. And actually, we're a busy service. We're all busy, aren't we, these days? And they were really good conversations that were sometimes getting a little bit overlooked. So, you know, we feel very blessed to have this ACP nurse that's focusing purely on that. So yeah, we're lucky.
And it's just making sure that information and that we do communicate regularly with our allied health professionals. So it might be we have regular contact with the dietitians if people are having treatment and they're struggling with weight loss, or the occupational therapists if people are needing equipment. We can pull on services either in the trust or out in the community, and we've got those good links now where we will share as much information as possible, and yeah, just make sure everyone's aware of the current situation, because letters do get sent out, but often they go into a huge GP mailbox and don't get looked at for several weeks, and by that point things have changed considerably. So we prefer to be proactive in ringing our community colleagues and actually discussing patients and keeping that dialogue open. And it works both ways. We have a lot of district nurses that ring us regularly to say they're in with a patient and can we give them the latest information. It does work quite well, we found, just to be able to have that. But just a little bit more about kind of the team, because it is important that we're able to prescribe as well, because that saves a lot of the burden on the doctors, and it's able to facilitate getting prescriptions quickly. Pauline actually runs the advanced communication course, so she's a facilitator for that. So we're encouraging our medical colleagues and other CNSs to attend that. And we run a lot of health and wellbeing events with our the health and wellbeing and living with beyond team here at the trust. And it's to get patients that now have what we call treatable but incurable cancer, to get them involved in these courses as well and getting the support, because historically it was only ever patients with treatable cancer that would attend. But the Living with Beyond team have been really good at embracing having this cohort of patients that are now living well for several years, to make sure they're getting the right support that they do need as well. And we also run a time and space course as well for carers and relatives of the family, and there's also a bereavement journey course that Pauline runs here at the trust as well for members of staff that have suffered a recent bereavement. So there's lots of things that we're kind of doing on top of just the enhanced supportive care role. Next slide, please.
So just talking about where we're at now. So we've been this service has now been set up for 7 years. So we're very much embedded within oncology. And just, I think something that I wanted to point out, we are uniquely nurse-led here, nationally nurse-led actually, and we very much use the oncologists rather than one individual consultant. So we develop very good relationships with the much wider MDT here. So just going forward, we're currently in discussions with radiotherapy to partake in the patient reported outcome measures via a new app called Nuna. We don't know a tremendous amount about it, but we are exploring how that might work for our team. We also lead on all the cancer of unknown primary workup, which I've never quite forgiven Lucy for taking it on when I wasn't here, but it's a whole new thing. And we've been shortlisted for several awards, the HSJ Patient Safety Award, Nursing Times and Team of the Year. But I think our proudest moment was winning the Macmillan Whatever It Takes Award last year for best practice. It was amazing to be recognised for the fact that we truly believe we do go over and above for our patients. We still work very closely with NHS England, and we are national clinical champions for ESC, which is how we met Nikki. Thank you, Nikki. So we're here to support other services that are just starting up or need some guidance. And very recently, we've